Bismillah ar-Rahman ar-Rahim. Welcome in this meeting, Egyptian Nephrology and Transplantation CME chapter meetings. And this is today one of the meetings for the CME chapter members, the very active members who shared me all through this journey since since 2021. We have a debate between two of our very eminent and very promising speakers, debate about protein restriction in chronic kidney disease. They will speak together, giving us the idea if it is a very useful idea to restrict proteins as a conservative treatment or a hazardous maneuver regarding care of patients with chronic kidney disease. First speaker, not an arrangement, but first speaker is Dr. Ramy Abu Bakr Elshahat, who is MRCP from Edinburgh, qualified, Egyptian Nephrology Fellowship qualified, and MD qualified from the University. He is currently consultant of nephrology in Royal Hospital in Muscat, Oman, and really one of my dear colleagues and with very high activities in CME chapter of Egyptian Society of Nephrology and Transplantation. The second one in this debate is my young brother and colleague in Cairo University, Abdelrahman Marzouk, who is the lecturer of nephrology and internal medicine in Cairo University and the vice head or the vice president of the internal medicine hospital, Cairo University Hospitals, Faculty of Medicine, Cairo University. And also one of the active members in CME chapter, Egyptian Society of Nephrology and Transplantation. All are the coordinators of, both are coordinators of this meeting. And I would like to welcome all our attendees and all our attending professors. Professor Hisham Said, the President-elect of the Egyptian Society of Nephrology and Transplantation in this meeting. And we expect from all of attending professors a very hot discussion and very hot scientific discussions following this debate after the lecture. So I will come to you after the lecture for the discussion. So please start. I think Abdelrahman will start the lecture. Start, please, Abdelrahman.
Okay, dear Professor Dr. Yasser, thank you so much. Today we will present a debatable topic, protein restriction or not. Our agenda today, prevalence and burden of CKD, rationale, safety, efficacy, eligibility, types of protein source and types of supplements, guidelines, cases, and take-home message. We know that CKD prevalence worldwide representing about 10%, 14 in males and 16 in females. And CKD prevalence in Egypt, 200 to 650 cases, 1 million population, 19th death annually, fourth leading cause in Egypt, 12th place in the world in the rates of deaths by kidney disease, and 7th place in the world in the rates of injury, and the number of patients with kidney than 52,000 people per year. And CKD represent an enormous healthcare burden affecting more than 840 million people all around the globe. No? And CKD is a major public health crisis, and its prevalence and cost are expected to rise, regarding the prevalence rising up to 16% increase to 2026, and up to 23% increase in the cost in 2026. And we know that the rate of mortality, rate of death increasing 41.5% from 1990 to 2017. And so the aim of these measures to slow the progression of a chronic kidney disease, delaying the progression, and lowering the incidence of CKD. Yes, lowering the incidence and slowing of the progression of CKD, it is our target as a nephrologist, as we know. What's your consensus, Dr. Ramy, regarding the management?
So regarding management of CKD, we all know our objective is treating of comorbidities like diabetes and hypertension, controlling of complication like acid-base disorders, dyslipidemia, anemia, and CKD MPD. But do we have a role for diet, especially for protein restriction, as a role, as an intervention for delaying or treatment of chronic kidney disease before the patient reaching for renal replacement therapy like dialysis or kidney transplantation? We all know we have the pillars for the slowing CKD progression, like ACE, like GL2, like mineraloreceptors antagonist, and finally we have GLP-1. But really, protein restriction have a role in delaying or improving CKD progression. Especially, we all know and targeting regarding nutritional intervention, we are aiming for adequate nutritional status, control of disease progression, delay renal replacement therapy initiation, and build up a good body stores for a good kidney transplant, and finally improve quality of life. We all know about different protein diet, like we have normal protein diet, which is equal more than 0.8 gram per kg, and low protein diet in this regimen, we are aiming for 0.6 gram per kg, and supplemented a very low protein diet. And in this protocol, we are aiming for 0.3 gram per kg with supplements. And we have high protein diet, which is targeting more than 1.2 gram per kg. So just to forget your attention, we will start our presentation with some cases, aiming at the end of this presentation, we will get a very rational control or management for this patient. Case number one, we have a young lady, 25 years old. She is no case of lupus. She is maintained on steroids and MMF, and she's quite stable for the past 2 years. And she is now CKD stage 3B with GFR around 35, with proteinuria less than 1 gram. And she did a kidney biopsy showing no activity. And she came to your clinic asking for protein restriction as a pillar for delaying dialysis initiation. This is case number one. Case number two, we have a 54 years old male. He is diabetic in insulin. He's CKD stage 4 with GFR around 23 with proteinuria 2.5 gram. And he was treated like non-biopsy proven diabetic nephropathy. And he also came to your clinic asking about the magic pills and if it's effective for delaying his CKD progression. Case number three, we have a 65 years old non-diabetic patient, CKD stage 5, with GFR around 10, and he's quite stable for the past 10 months, and he is already on low protein diet. And he presented in the hospital with chest infection and AKI. And do you think he will need some adjustment of his nutritional plan, or he can continue on the same plan? Finally, case number four, we have 81 years old male patient, diabetic and hypertensive. He is CKD with GFR around 12. He has some good urine output and well-controlled CKD-related complication, but he has some uremic manifestation. And he came with his family asking about low protein diet to avoid renal replacement therapy. So do you think, Dr. Abdelrahman, those patients will get any benefit from protein restriction for delaying initiation of dialysis? What is your rationale for this issue?
Yes, I have rationale. We know that the protein metabolism in chronic kidney disease is focusing on protein and sodium restriction, which is allow metabolic and flow control even during the advanced CKD stages. A very restricted dietary treatment may reduce signs and symptoms of uremia, and possibly the CKD progression may counteracting the nutrient waste products accumulation and the related adaptive mechanism. Yes, in case of high protein intake, it will lead to afferent arterial vasodilatation and renal angiotensin, efferent arterial vasoconstrictions that will lead to glomerular hypertension and so glomerular hyperfiltration and increasing the proteinuria. And it is a vicious circle: glomerular hypertension, damage to glomerular structure, increased intraglomerular pressure, damage, and so on and so on. So we should abrupt this vicious circle. Yeah, renoprotective mechanism related to protein. Can you imagine if we have a low protein diet, this will lead to vasoconstriction of the afferent arteriole, that will lead to decrease the intraglomerular pressure, decreasing the hyperfiltration, so decreasing the proteinuria, slowing CKD progression. And on the other hand, decreasing intraglomerular pressure lead to decreasing the meningeal proliferation, transforming growth factor beta, and lead to decreasing interstitial proliferation and fibrosis, and so slow CKD progression. Can you imagine if we have the synergistic effect, low protein diet affecting the afferent, and in the same time using RAS inhibitors affecting the efferent by vasodilatation, leads to decreased intraglomerular pressure, so it will lead to slowing of the CKD progression. So with a low protein diet, we have a lot of benefits: reducing glomerular fibrosis, reduced glomerular hyperfiltration, reduced proteinuria, reduced nephrotoxic byproducts of protein metabolism, improving metabolic acidosis control, reduced urea generation, improved glycemic and lipid profile, reduced phosphate load.
So
I have a rationale.
yeah, I agree with you, Dr. Abdelrahman. We have a good rationale here. But to be honest, I have multiple concerns regarding this approach, especially who is eligible for such an approach. Is it safe to be used? And is it effective approach? I have major concern regarding safety, to be honest, especially we all know about uremic malnutrition and protein energy wasting. We don't want to see our patient like this. It's like nightmare. And we all know that protein energy malnutrition, it's a strong predictor of mortality, especially once we are speaking about our patient, which reach end stage. We all know about reverse epidemiology, in which the obese patient survive much better than vegetative and malnourished patient. And regarding the mechanism of protein energy malnutrition, it's very common in our patient because of anorexia related to uremia. And also we are advising our patient to restrict protein intake. And in the presence of inflammatory cytokines, our patient develops some kind of proteolysis, which is end with protein energy malnutrition. And to be honest, this is a very common side effect. Even you can see this is in USA, in the first stages of kidney disease, even the prevalence of protein energy malnutrition can reach 50% of cases. And once we are speaking about CKD stage 5, it is reaching 75%. This is about the Lancet documentation in this study. And a major concern about the elderly group, which is not a small group, as you can see, for a patient over 70 years, it's almost 20% of patient has chronic kidney disease. And for a patient more than 80 years, almost 30% of patients had chronic kidney disease. This means this group of patients are more liable for malnutrition, sarcopenia, and of course, morbidity and mortality. And you can see how concerning is this issue, even for ISPIN, which is maintained and she's advised for keeping a protein diet at least 1 gram for such a group of patients. So low protein diet, still you have a concern regarding this protocol?
Yes, I have a lot of benefits regarding the protein diet, as we mentioned, that lead to better uremia control and postponing of dialysis, but with risk.
Yes, with risks of protein energy malnutrition and sarcopenia, as we mentioned, especially for our group patient, elderly group. So do you think still this is a safe protocol to be administered for our patient?
Yes. If we revise the literature in 1997, effect of dietary protein restriction on nutrition status, MDRD study, one of the biggest trials in this issue, we will find that in the low protein and very low protein diet group, serum albumin increased, where serum and transferrin body weight decreased, and low protein diet wasn't correlated with a higher rate of death, hospitalization, or with a progressive decline in any of the indices of nutritional status after controlling the baseline. And the conclusion was these analysis suggests that low protein and very low protein diet used in the MDRD study are safe for periods of 2 to 3 years. But physicians who prescribe low protein diet must carefully monitor patients' protein and the energy intake and nutritional status, so individualization is very important. Regarding the nutrition and the outcome on renal replacement therapy of patients with a chronic renal failure treated by supplemented very low protein diet in 2000, we will find that the concern about safety, body mass index, and serum albumin concentration remained unchanged overall. Supplemented very low protein diet can be safely used in patients with a CRF without adverse effect on the clinical and nutritional status of patients. The outcome of patients on renal replacement therapy is not affected by period treatment with supplemented very low protein diets.
Okay, so we can agree now. It's some kind, once you are select your patient properly with good monitoring, it looks like it's safe to be used. Okay, so let's go for the second point. Who is eligible? So quickly, I will introduce our recent guidelines. It shows we have non-diabetic non-dialysis patient and diabetic non-dialysis patient. For those diabetic and non-dialysis patients, they are eligible for low protein diet, I mean 0.6 to 0.8 gram per kg. For non-diabetic patients, they are eligible for PES regimen, which is include low protein diet or supplemented very low protein diet. But I have to focus that our group of patients also on hemodialysis and peritoneal dialysis, our group or AKI on dialysis, those group of patients are not eligible for protein restriction. And such a group of patients are mandatory to be on the higher side, even high protein diet, more than 1.2 gram per kg. Not only this, we have to go for full history assessment. Metabolic stable. Patient should be metabolic stable. His chemistry and allometric measure should be accepted. And during a follow-up, patient should not showing any signs related to protein energy malnutrition. And by definition of metabolically stable, patient should have no activity of active inflammation, infection, no hospitalization in the past 2 weeks, absence of any uncontrolled diabetes, consumption disease such cancer, antibiotics, absence of significant short-term weight loss in the previous time. So not all the patients are eligible for nutritional intervention, especially for protein restriction. And we have also a lot of concern regarding its useful or effectiveness. Especially, you can see Dr. Abdelrahman in this study published in New England Journal of Medicine in 1994, which is mentioning, as you can see, protein restriction showed some improvement regarding decline in GFR at the first, then both of them didn't show any benefit in the long-term follow-up. And we have also this study published in American Journal of Medicine in 2009, which showed the effect of low or versus moderate protein restriction in CKD progression, and it was quite significant study. It included around 420 patients, CKD stage 4 to CKD stage 5. It was randomized. And the conclusion is low protein diet didn't decrease the risk of death or even dialysis therapy in comparison with moderate protein diet. Finally, we all know about the MDRD study, which is published in 1994, which was very good quality study, including around 1,500 patients. And finally, showing the same results. It's working for the first 4 months, and then there is a small benefit of this dietary intervention. So do you think still it is effective?
I'm with you in some point, but if we revise the literatures in 2006, we'll find that effective dietary protein restriction on the progression of chronic kidney disease, long-term follow-up MDRD study, showed that In this 12-year study, the average rate of GFR decline was 4 milli per year during the mean duration 2.2 years, and the relatively few patients developed kidney failure during this period. Can you imagine if we have two patients with a GFR of 40 milli per minute? The first patient GFR decline 4 milli per minute per year. This patient will be in need, and the other 3 milli per minute per year. The patient with decreasing GFR 4 milli per year, he will be indicated for hemodialysis after 8 years. But on the other hand, the patient's GFR declining 3 milli per minute per year, the patient will be indicated for dialysis after 11 years. So it is very good to postpone. And we will find that the recommendations, previous recommendations and recent recommendation, previous recommendation started low protein diet or restriction with the GFR less than 30 or 20, but recent guidelines, KDIGO and the KDIGO, recommended early protein restriction less than 60 milli per minute, and this is due to the effect of the protein restriction on the progression of a chronic kidney disease. Start early as possible, but with a risk. And if we revise the literature, it's a meta-analysis, a total of 1,413 patients. The conclusion, dietary protein restriction effectively slows the progression in diabetic and non-diabetic renal disease. And in 2000, on 1,494 patients, protein intake 0.6 recommended, reduce the occurrence of renal death by about 40%. And 2006 reduced the occurrence of renal death by 31% on 1,500 patients. 2009 reduced the occurrence of renal death by 32% in 2,000 patients.
See, Dr. Abdelrahman, did you revise this study published in 2022, which is surprisingly, it was including around 3,000 patients. And in the opposite, it shows that reduce the number of people with advanced kidney disease. It didn't improve much with low protein diet. And also, low protein diet didn't differ in the number of patients with less severe kidney failure. And in conclusion, they just say probably low protein diet can slow the progression of kidney failure.
I'm with you, but your studies may be old. If we can imagine, some of the trials on low protein diet were conducted before treatment with RAS and the sodium glucose transporter to inhibitors. And we know protein restriction was the first prescribed event to delay the progression of chronic kidney disease from 1930. But can you imagine the synergistic effect if we are using a low protein diet with RAS inhibitors and sodium glucose transporter 2 inhibitors? It's a complementary effect has been postulated that these strategies may synergize and maximize their combined effect on delaying CKD progression. Your studies may be old before this era. I ask you a question, what about diet or dialysis, especially in the elderly patients? If we revise the efficacy and safety of a very low protein diet when postponing dialysis in the elderly in 2007, we will find that this is 112 patients observed that very low protein diet and keto analogs was an efficient strategy to delay the need for dialysis. And the mortality rate wasn't different between the two groups. And the hospitalization rate was higher in the dialysis group. And we know the complication associated with dialysis. And this is conservative management in end-stage kidney disease between dialysis. In 2024, conservative management with a low protein diet. Low protein diet significantly improve urea level, calcium, phosphorus, metabolism, and metabolic acidosis, slow the progression of estimated GFR, limit hospitalization, reducing hospital access related to dialysis complications, which are more frequent in older patients. Conservative managements allow them to maintain their habits with a slight impairment of quality of life. And we know in elderly, hemodialysis has a negative impact on the quality of life and the frailty, as we know, especially in the elderly. And this is the study 2007 with the 296 patients. The conclusions supplemented very low protein diet was effective and safe when postponing dialysis treatment in elderly patients without diabetes.
So, yes, I can understand regarding your concern of quality of life, but here we have a meta-analysis which is showing the comparison between dialysis and conservative management in chronic in elderly patient with advanced kidney disease. You can imagine this meta-analysis included around 11,500 patients, and it showed quite significant difference in survival between patient who started dialysis and other patient on conservative management. Yes, I know there's some kind of heterogeneity which is precluded definitive conclusion, but at the end, they concluded that patient values and preferences and shared decision making and symptoms burden should be discussed. And also we have another meta-analysis published, and it included around 16,000 patients, which showed dialysis initiation reduce mortality in comparison to conservative management.
Can I say that the guidelines on dialysis start open the way to medical nutrition therapy, the Canadian guidelines in 2014, when recommended intent to delay the dialysis strategy, where patients with estimated GFR below 15 milli per minute are closely monitored by a nephrologist with dialysis initiated when clinical indication emerge or the GFR is 6, which is should occur first. Our recommendation places a high value on the avoidance of burdensome and resource-intensive therapy that doesn't provide measurable benefits when started before the development of a clinical indication such as the uremic symptoms. So, conservative management, if we consider patients over 75 years old, we should consider conservative management, assessment of urine output. No urine output, go to dialysis. But if yes, clinical assessment, comorbidities, performance, social patients determination. If a high comorbidities and poor performance status, we can consider life expectancy less than 6 months, palliative care more than. We can do diet restriction and conservative management to avoid dialysis in this age with a frailty and for improving the quality of life and avoiding the hemodialysis. But if there is an indication, start dialysis from the start, as we mentioned. So dialysis, slowing CKD progression and postponing dialysis is a very important point, especially as we mentioned in elderly patients, but we should respect the incidence and risk of malnutrition and sarcopenia in old patients. So the key is personalization, individualization, mediation should be considered in this special situation.
Okay, so do you have any preference for animal or protein diet?
Yes, regarding animal or animal protein or plant protein diet, the source of protein, potential benefits of diet for patients with CKD plant-based, we'll find that a plant protein diet associated with less uremic toxins due to gut dysbiosis correction, less hyperphosphatemia, less acidosis, less proteinuria, and less vascular calcification. So plant-based diet is beneficial. And there is a very important point, as we considered before, the quantity of protein with a low protein diet, we should consider the quality of protein. If we revise this, we will find that the plant protein improve the metabolic acidosis, hyperkalemia, hyperphosphatemia, hypertension, uremic toxins, and inflammation. So plant-based diet is more beneficial than animal diet.
Okay.
And plant-based versus animal diet, we will find that there is a superior to mixed diets and improving the metabolic disturbance, and it is nutritionally safe in CKD patients. But this slide is a very important. We should respect this point. 100 gram of meat contains only approximately 25 gram of protein. This is a very important point to avoid malnutrition, especially in the elderly patient. We should calculate the proper dose. Can I ask you, Dr. Ramy, a very common question every day in our clinics? The patient asked us, Doctor, I need the magic pills for the treatment of a chronic kidney disease. What do you think about this magic pills? Is it effective or not?
You know, Dr. Abdelrahman, patients are coming to us thinking about keto analogs, like as you stated, as a magic pills. And maybe they are thinking this magic pills, they can allow them to avoid dialysis. But to be honest, keto analogs is just a modified amino acids without amine group. And it convert their respective amino acids without providing additional nitrogen. And the main rationale behind this magic pill is decreasing nitrogen waste, oxidative stress, and inflammatory response, including transforming growth factor beta and protection against the hemodynamic changes in glomerular filtrations. So they are not magic pills. And we are, once you are speaking about keto analogs, we are not only considering keto analogs, even branched chain amino acid can be used. It's just a supplement. And the main aim for benefit of this supplement is maintaining protein energy status without increasing nitrogen waste and reducing phosphorus and acid load, and also decreasing protein degradation and enhancing protein synthesis. So it's just protein supplement. And to be honest, even in guidelines, they're mentioning keto analogs or amino acids as supplemented for patient eligible for very low protein diet. And even you can see this is meta-analysis and systematic review. They even studied using the magic pills in the hemodialysis patient. So it's just a supplement. And the conclusion is it can be used even for improving the nutritional status in patient in hemodialysis. It can help regarding prevention of hyperparathyroidism. And you can imagine as a concern regarding as a proper dose for every 5 kg, you have to give one tablet. So you can imagine if you have a patient with 100 kilogram, he is supposed to receive 20 tablets per day. So it's a huge concern regarding tablet load, especially for our patient who already taking polypharmaceutical drugs. So let's go for guidelines.
Yes. Let's go to the guidelines recommendations. The summary of various guidelines and nutrition recommendation, we will have, as we mentioned before, protein restriction in the recent guidelines started from around 30, 20, 25 milli per minute. But in the recent guidelines, KDUKI 2020 and KDIGO 2024, the recommendation to start protein or low protein diet from less than 60 milli per minute. And this is with protein restriction or low protein diet.
So we will go quickly for the last update from KDUKI guidelines in 2020. And as we mentioned, proper assessment at the beginning is very crucial for those group of patients, including some laboratory investigation and also some clinical assessment, including hand grip strength and BMI, and finally, assessment of protein calories intake. And of course, assessment of body weight, especially in our group of patient who has advanced kidney disease with salt water retention, it will be challenging. And again, we have to make sure you understand we are speaking about protein restriction. But on the other hand, energy intake should be maintained for all our patients from 25 to 35 kilocalorie per kg to avoid malnutrition. And as we stated before, regarding non-dialysis, non-diabetic patients, they are eligible with evidence of 1A in KIDOQI guidelines because, as Dr. Abdelrahman mentioned, there is a lot of evidence, including meta-analysis, showing some benefit of low-protein diet. And they stated that patients not on dialysis, without diabetes, with CKD from 3 stage to 5 stage, are eligible for low-protein diet or very low-protein diet. But if the patient is diabetic, not on dialysis, he is only eligible for low-protein diet. He's not eligible for supplemented very low-protein diet. And once they spoke about the quality of protein and animal or plant, they stated there is no insufficient evidence and both source can be used. To summarize the KIDOQI 2020, they mentioned diet control, diet intervention is indicated for all stages. For non-diabetic patient with evidence of 1A, they were advised for both regimen, either restricted, very restricted with supplement or only restricted. But for diabetic patient, only moderate restriction from 0.6 to 0.8. And about the protein source, you can choose whatever you want, plant or animal.
Regarding the KDIGO and DKD 2022 and KDIGO 2024, we'll find that patients with diabetes and chronic kidney disease should be treated with a comprehensive strategy to reduce the risk of kidney disease progression and cardiovascular disease. And one of the important points, diet, healthy diet. And regarding the lifestyle, healthy diet was the first. So focus on protein. The recommendation was a protein intake of 0.8 gram per kg per day in CKD stage 3 to 5, but it's 2C. We suggest maintaining protein intake of 0.8. Avoid high protein intake, more than 1.3. In adults with CKD who are willing and able and who are risk of kidney failure, consider prescribing under close supervision a very low protein diet 0.3, 0.4, supplemented with essential amino acids or keto acids analog, and don't prescribe, very important, don't prescribe low or very low protein diets in metabolically unstable people with a chronic kidney disease. And regarding 2024 KDIGO, the plant-based food is preferred, as we mentioned. And the conclusion, ambitious indication to normalize protein intake in patients at risk of progression. Otherwise, just avoid more than 1.3. No indication for a moderate protein restriction. Very low protein diet 0.3 in selected cases. Preference for plant-based diet, and the magic pills may be added to the diet. But I think we should search for a proper guidelines. Especially, they didn't mention the elderly, which are presenting a lot of CKD patients, as we know. There was no any recommendation regarding the elderly. We should search for this, for the previous guidelines.
Okay, so let's go for cases we already mentioned in the first presentation and to apply what we already discussed. So we have case number 1. We have a 25 years old female patient. She is lupus on steroids and MMF, and she's stable with CKD stage 3P with GFR around 35, with proteinuria less than 1 gram, and kidney biopsy show no signs of activity. And she's asking about protein restriction to delay dialysis initiation. We can agree now there is some rationale, which is, and according to the studies, it's effective regimen, but let's see about safety and eligibility. So is it safe to be used for such kind of patient? Before saying yes, we have to go for assessment. As we mentioned, assessment should be including chemistry, BMI, muscle mass, and dietary intake assessment. And after we agree if she's eligible and she's safe to be started with such regimen, we have to do follow-up. And if the patient start to develop some kind of affection of the above 4 parameters, protein energy malnutrition should be diagnosed and protein restriction should be aborted. So quickly, as you can see, we have approach for assessment of the four main domain, including serum chemistry, body mass, muscle mass, and dietary intake. And I think it's better to be done by a professional nutritionist. So regarding safety, yes, she is considered quite safe after a proper assessment and proper follow-up. About eligibility, as we revise the guidelines, an adult patient with CKD stage 3 to 5, GFR less than 60, they are eligible for the protein restriction as long as they are metabolically stable, not on dialysis, and without diabetes. We can go for either very low protein diet with supplements or low protein diet. So she's eligible.
The second case, we have a 54 years old male patient, diabetic on insulin, CKD stage 4, with a GFR 23 and proteinuria 2.5 gram. He came to your clinic asking about magic pills and if it is beneficial for him to delay CKD progression. Regarding the eligibility, in the adult with a CKD stage 3, 5, and who has a diabetes, metabolically stable and not on dialysis, it is reasonable to prescribe under close clinical supervision a dietary protein intake of 0.6 to 0.8 per kg body weight per day, low protein diet to maintain a stable nutritional status and optimize glycemic control. No, he is not eligible, as we know that diabetic patients vulnerable to malnutrition and ketosis. So just low protein diet. No rule for restricted protein diet. Very
So
specific.
case number 3, we have a 65 years old patient, non-diabetic, CKD stage 5 with GFR around 10, and he was quite stable for the past 10 months, and he's already in protein restriction, and he came with chest infection and AKI. Do you think he need adjustment of his nutritional status, nutritional plan, or continue the same? We already knows about this kind of group of patient with initiation of dialysis, AKI, hypercatabolic state, metabolically unstable, he is infection now, should be on the higher side, not on protein restriction for proper recovery. So he's not eligible for current management, and he should be on high protein diet. So he should be adjusted.
Last case, 81 years old male patient, diabetic and hypertensive, GFR 12. He had a good urine output and will control CKD-related complications, but he has some uremic manifestations. He and his family asking about low-protein diet to avoid renal replacement therapies. As we mentioned, protein restriction may postpone the dialysis, especially in the elderly patient, but with the risk for developing malnutrition. But if we have a patient over 75, considering conservative management, as we can, if the urine output preserved, no, go to dialysis. But if there is a proper, good urine output, yes, clinical assessment, comorbidities, performance, social status, and the nutritional status. If high comorbidity and poor performance status, assess expectancy, less than 60 months, palliative care, more than 6 months, we can go with the protein restriction, but nutritional assessment and monitoring is very important. And as I said before, especially in elderly, individualization, remediation, personalization, they're very important.
Okay, so let's summarize our presentation and give the home message. Considering the average yearly cost, morbidity and mortality and burden of dialysis, protein restriction, it's a solution and an option for delaying dialysis treatment, which will allow significant financial saving and better patient care as long as proper selection and good monitoring.
The personalized medicine is one of the emerging clinical models in the new millennium.
We have a new option now, like we can coming in the horizon, like incremental dialysis combined with nutritional therapy, and this may an option for avoiding the abrupt start of thrice weekly hemodialysis.
Further research will be required to establish the optimal ketogenic dose and role of this diet in the era of the new available medications.
We as a doctor believe that making a good decision is crucially skill for every single step.
Thank you so much, our dear professors and dear colleague.
Thank you.
Thank you so much, Dr. Abdelrahman, Dr. Ramy, for this very, very, very interesting and comprehensive lecture about protein restrictions. You raised many issues, started with case presentations, and started in a debate forum, one taking the limb of using protein restriction and the other is against. But finally, I think the message you gave is to manage in selected cases and deal with every case, personalize your decision according to case selection and frequent monitoring and meticulous monitoring with the patient who is using this type of treatment in chronic kidney disease. And you answered clearly the question of the magic pills, as they are just nutritional supplements, no more to be used in certain indications. Please select your patient carefully. Please select your patient carefully. And when you decide to do protein restriction for the patient, please monitor your patient carefully, just avoiding malnutrition and getting the benefits. Also, the combination therapy now with recent drugs, especially SGLT2 and ARPs discovered yearly, and RAS system inhibitors discovered yearly, are very important to be used together in delaying the progression. Also, the importance of decision in elderly patients over than 75 years in delaying the decision of dialysis or replacing conservative treatment with protein restriction, delaying the decision in patients who can tolerate with good urine output is a very important issue raised in this talk. Thank you so much for this very comprehensive talk. And we have many comments and I think few questions. Which is first in morbid obese patients with GN, difficult for renal biopsy, weight education with bariatric surgery, or low protein diet, or both at parallel lines? Very difficult question. Obese patient, GN, cannot take a biopsy, definitive treatment, just delaying the progression using conservative treatment.
Abdelrahman, you want to answer or I can go ahead?
Go
Okay.
ahead, Rob. Go ahead.
Okay.
Go ahead.
So as I understand, you have a patient morbid obese and he presented with some kind of proteinuria and you are suspecting that he has some kind of secondary FSGS related to obesity. So if you are just expecting some kind of secondary FSGS related to obesity, which is common finding in clinical practice, so I think this patient will gain much benefit from bariatric surgery or the new drugs like GLP-1 for aggressive weight reduction to saving his kidney. But of course, if the patient presented with RPGN, you have to do it even with high risk to give the proper management. Low protein diet for patient with, again, we are not restricting the energy. So the patient is still taking around 35 kilocalorie per kg. So I don't think he will have some kind of improvement regarding his nutritional status and his BMI. Even the studies which is mentioning the role of low protein diet, they are focusing patient will not suffer from severe weight loss. So it's not eligible, he is not eligible for such approach. I think for again, to summarize, if you are suspecting something related to his obesity, so bariatric surgery or GLP-1, but if you are suspecting another kind of GN, he needs a need for kidney biopsy with high risk to give him the proper management.
Here, I think here is another factor to be considered is the amount of proteinuria
Yes.
in this patient.
Yes.
Amount of proteinuria.
Yes.
Professor Hisham Said.
Thank you. Thank you very much, ya Shabab. Really, it's a night orchestra, and unfortunately, it will be this night low protein diet. But it's I enjoy the orchestra between both of you. The message is clear and the science is clear. However, there is something also we have to put in mind that patient metabolism is different between each another. What I mean that there is what's called adaptations. Any proteins in the body is under both the metabolism with degradation and synthesis. So at the balance between degradation and synthesis that maintains the protein positively in the normal physiological range. With physiological part of the low protein diet, the protein degradation decrease. So the net degradation to protein synthesis does not change. And this find that serum albumin on those patients does not drop, not due to proper nutrition but decreased degradations by the system physiological adaptation, not accommodation. It's adaptation, physiological adaptation. The key point here is inflammation, which is turned on or off the degradation step. So protein restriction in inflammation is not recommended because protein degradation is high and over activating the degradation against the physiological way of adaptation. My concern here is sometimes going to dialysis is the best option, especially in hypercatabolic patients. They didn't define in these guidelines when to stop and move to dialysis. Probably it may be mentioned in other guidelines. But I have a question here for you. Does any guidelines put a marker of inflammation on the algorithm of protein? For example, we have to measure CRP first before deciding what we can monitor for adjusting the protein intake and so on, so on, so.
Thanks,
No, I
Dr.
didn't think so,
Uh,
Dr. Hisham.
Same.
So it is an open end for all, as we usually see in nephrology, that there is no a clinical map or algorithm, clear algorithm in this nutritional debatable for more than 3 to 4 decades. I think in the next guideline, we have to make sure that patient-centered approach, as in dialysis right now, we are not defining KT over V. All the dialysis procedure is going for a patient-centered approach, what the patient need and how I can supply for the health. I think in the next guideline, there may be biomarkers, better biomarker, like pre-albumin or serum albumin and additional CRRP or any additional inflammatory like serum ferritin to judge which patient will get benefit from low or normalized protein intake. And thank you very much. I really enjoyed.
Thanks, Dr.
Thank you, Professor Hisham. We really enjoyed your comment. You are stressing on a very important point, considering inflammation and the role of inflammatory markers in assessing the nutritional status and assessing the eligibility for protein restriction and its impact on nutrition. Professor Riyad Saeed, unmute yourself, please. Professor Riyad, unmute yourself.
مساء الخير.
اهلا مساء النور، اهلا وسهلا في دكتور رياض، اتفضل.
بصراحة كانت يعني محاضرة قيمة جدا جدا. طبعا I have few comments about it. We have to categorize really our patients who are already CKD 4 and 5 not on dialysis, patient on hemodialysis, patient on peritoneal dialysis, and patients that are not really having impaired kidney function, like nephrotic patients. These are 4 categories of patients with renal disorder. Patients who are in stage 4, 5, to slow their progression, I think we agree that they should have protein restriction in the amount of 0.85 gram per kilogram body weight. Less than that, 0.5, what really we hear, or the magic pill, or that we have some complication with that ketosterol, usually hypercalcemia and others, and usually the body will destroy itself. So we need protein in the range up to 0.85 gram per kilogram body weight. Patients, when they are already on dialysis, especially the elderly, please, they don't eat. Let them eat. Let them enjoy their food. in the range of 1 gram per kilogram body weight. Patient on TD, they lose a good amount of protein in their fluids. So such patient, if you restrict their fluids, they're going to go really in malnutrition. So you have to allow them to eat good amount of protein up to 1.5 gram per kilogram body weight. And don't worry about the other things. You can manage their phosphorus, you can manage their acidosis and others. Patients who are not really in renal failure or CKD patient, but they are nephrotics, like minimal change disease or others, such individuals, there was a good amount of protein in their urine. So we have to let them eat well, up to 2 grams per kilogram body weight. So this really what we are doing, the current practice that I'm doing. I don't know what the comments from my colleagues, the two speakers.
Dear Professor Riyad, I think regarding the hemodialysis, we recommend the high protein diet, hemodialysis or peritoneal dialysis. At the stage of CKD, stage 4 and 5, as you mentioned, 0.8, but individualization may give a rule for less protein if it will affect the kidney and delaying the progression and delaying or postponing the hemodialysis, especially in adults, not in elderly. The last point regarding proteinuria, as you mentioned, proteinuria, the patient lost a lot of protein in urine, but in case of a high protein diet, as you mentioned, 2 gram, this will be reflected on the kidney, increasing the intraglomerular pressure, leads to more and more damage of the kidney.
But if they have normal creatinine, normal GFR, you have a young individual who's really nephrotic, and yes, in fact, his GFR around 120 or 130. They don't have so far a trouble with their filtration capabilities. So such individuals, they need a good amount of protein. Otherwise, they are coming with so fluid overload, the meta situation. So they need really to supplement such individuals. It's unfair, really, to restrict their proteins. They are losing a large amount of protein till they really recover their disease by the whatever therapy that we are giving them.
We can agree, Professor Riyad, they are not eligible for the low protein diet.
Okay.
So yeah, at least no low protein diet, either normal 1.2 gram per kg or even higher. We can, this is no consensus agreement regarding those group of patients, but by all definition, they are not eligible for low protein diet. So protein restriction for nephrotic syndrome with normal creatinine and normal GFR, I totally with you regarding at least the normal protein diet.
Yes, but not high protein diet.
No, at least yes.
Normal. No place, I think, for protein restriction here with normal.
Yes.
GFR.
Yes.
Thank you, Professor Riyad, for your comment.
Thank you.
I can't see any comments. My last question is for me. What about? Can you inform me about protein restriction and its relation to various electrolyte and pH bicarbonate levels? If you have any information about this in chronic kidney disease patient, any modulation of your recommendations according to the level of these electrolytes and pH status and metabolic acidosis, for example?
As we mentioned regarding protein restriction, with improving the nutrient waste products, it will lead to improvement of the acidosis. But there is a risk of, in some situations, hyperphosphatemia, hyperkalemia, especially with animal proteins. But if we are going to delay the progression of chronic kidney disease, we can use potassium chelating agents for proper management with the protein restriction.
And no change of the amount recommended regarding these complications?
No.
Oh, okay. Question from
Dr. Yasser, I would like to ask Dr. Abdelrahman, thanks first for the very nice lecture, and thanks Dr. Ramy, and thanks for the choice of this topic. Abdelrahman, do you think plant-based diet can replace?
Here.
Yes.
Can I introduce you?
Uh,
بروفيسور سمير
okay.
بروفيسور سمير الخشاب Professor of Nephrology في قصر العيني wants to comment. اتفضل.
Thank you, Dr. Yes. Thank you, Dr. Abdelrahman. Thank you, Dr. Ramy. Thank you, Dr. Yasser, for the choice of this nice topic. There's a lot of talk now in many journals about the PLADO or the plant diet as a substitute for the protein restriction. For a long time, we used to tell our patients not to eat vegetables for the high potassium intake. But there is an opinion that potassium in the plants is excreted well in stools. And so do you think, Dr. Abdelrahman, that Play-Doh can substitute the protein restriction, or do you think Play-Doh will add to the problem by making the patients more hyperkalemic?
No, Dr. Sair, as I mentioned in some situation, يعني plant-based diet is preferred than protein diet. يعني in Play-Doh, low protein diet 0.6, 0.8, and plant dominance more than 50%. Sodium would less than 4 gram, and adequate energy intake 30 to 35 in Play-Doh. I think the recommendation regarding safety, the serum potassium changed with hyperkalemic in some patients. But I think, as I mentioned, if we are using the potassium chelating agent in this situation with the low protein diet, this may lead to delay the progression of chronic kidney disease.
I have also commented, Dr. Zahir. Thanks for this comment, excellent comment. And as you stated, for plant protein, we are our first impression once the patient start to eat more plants, he will be more exposed for hyperkalemia. But actually, this is not a proper the situation. Actually, as you stated, potassium in vegetables and plant source are not commonly associated with hyperkalemia, and in the presence of the new generations of potassium chelating agent, it's not a big issue. And we can, as we saw in the Kuduki guidelines 2024, they preferred the plant protein, as you stated.
Thank you very much. I would like just to add one more comment that I think useful to everybody. We always tell our patients not to eat salt, and we somehow forget to tell them not to eat canned food. All canned and processed canned food contain much more salt than the patient's ability to restrict his salt as the usual salt. So we should always remember to tell our patient not to eat canned food. It's very bad, and it contains lots of sodium. And the notion of using this new Himalayan salt is also very bad because it contains some potassium. And I see lots of doctors now recommending that Himalayan diet for patients who are hypertensive, and recommending it for patients who are not in renal failure but have hypertension, as it contains potassium, claiming that potassium is good for hypertension. But the Himalayan salt contains 4% potassium and 95% sodium. So I know this is out of the protein restriction issue, but I like to say that to bring a message to everyone. Thank you very much, Dr.
Thank you, Professor Zahir. I think it should be considered, especially with the take of RAS inhibitors and the newly coming drugs, finerenone. Question from Professor Ahmed Faid, Professor of Nephrology, Qasr Al Aini. He is thanking you for this great presentation, and we really all thank you. What about the role of probiotics in hypercatabolic chronic kidney disease patients? Ramy, do you have an information about it?
No, to be honest, it's away from today's topic, because we are speaking about protein restriction, but regarding probiotics, we can look for it. To be honest, I don't have the answer.
Okay, and I think Abdelrahman, any information regarding the topic of this?
No.
It's okay.
No,
okay. We can have a specific session for probiotics to answer this very important question later. Thank you all, and thank you. And we are coming to the end of this very interesting session.
Thanks for all of
Thank
you
you,
for
our
attendance.
speakers, Dr. Abdelrahman Al-Maghrabi, Dr. Ramy Abu Bakr, for this very, very interesting orchestra, as Professor Hisham said, regarding protein dialysis, protein restriction, or protein use in chronic kidney disease patient as a method of conservative treatment. Thank you for all our attending professor, Professor Hisham Al-Sayyid, Professor Riyad Saeed, and for all, Professor Saeed Al-Khashab, Professor Ahmed Faid, for all, and thank you for all our attendees for this, their attendance and their active share and interaction during this session. Meeting you next Wednesday, inshallah, in our usual time, will be 8:30 p.m. Cairo time, and see you. Excuse me to close. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.